Good afternoon, everybody, and welcome to our 18th prestigious research lecture. It's wonderful to see that things are getting back to normal and we have a full auditorium here today. I'd also like to extend a very warm welcome to all the family, friends and colleagues who are joining us both from locally and globally. They couldn't be here in person today, but they have taken the time to join us online. So the Faculty of Health Sciences Research Office initiated the prestigious research lecture series in 2009, and we've generally hosted one or two of these lectures every year, with the exception of the last couple of years. So it's great to see that we're all back in the room and we're back on track. The aim of these lectures is to provide an opportunity for at least two of the faculty's top researchers to present key aspects of the research in a specific area. The target audience includes members of the wider medical and research community, as well as members of the public. And we know it is important for us to share with people beyond the usual university and academic community what research we do, and to showcase some of the latest research news in the fields where we are fortunate to have leading experts. So the lecture tonight will be presented by Professor Steve Tollman and Professor Kahn. Professor Steve Tollman is the founding director of the South African Medical Research Council and WITS Rural Public Health and Health Transitions Research Unit, and is responsible for its world-class health and socio-demographic platform, as well as multidisciplinary research spanning throughout the life course. He is a research professor in the School of Public Health at WITS and also a faculty member at the Harvard Center for Population and Development, obviously at Harvard University. So back in 1990, he moved to Bushbuckridge, and over the last 3 decades, he has built a globally leading research institution. Professor Kahn is also a personal professor in the School of Public Health and is principal scientist in the SAC WITS Rural Public Health and Health Transitions Research Unit. She has devoted 30 years to working in rural South Africa and the sub-Saharan African region. Since the inception of the Agincourt Health and Socio-Demographic Surveillance System in 1992, she has led work on mortality and cause of death measurement, using verbal autopsy to track transitions over a period of dramatic socio-political change and the HIV/AIDS epidemic in our country. She leads a research portfolio on adolescent and young health, adult health and development, including HIV prevention, non-communicable disease risk, and mental health. So this year, 2022, they are celebrating 30 years of the Agincourt Health and Socio-Demographic Surveillance System. It is an incredible achievement and a testament to their passion and dedication to their work. Now, I want to break protocol and also say that aside from being highly respected, internationally recognized researchers, I think I speak for most people here when I say they are actually both wonderful human beings and they're just such nice people, and it's really a privilege to know them. Okay, so back to the reason we're having this lecture as well. In the interest of stimulating public debate and comment on our research, we invite an external researcher to serve as a commentator at the end of the lecture and to remark on the work presented by Kathy and Steve, and to take questions from the audience. So this year, we are very honored that Professor Mosa Moshabela has agreed to be here. So Professor Moshabela is a professor of public health, and he's the Deputy Vice Chancellor for Research and Innovation at the University of KwaZulu-Natal. He's also part of us, right? He's an esteemed academic and clinician scientist, and he leads the Quality Health Systems and Transformation Center in South Africa, which is a collaboration with the T.H. Chan School of Public Health at Harvard University. He is also a member, a faculty member in the HIV, Infectious Disease and Global Health Research Institute at the University of Washington in St. Louis. He's also the chair of the Standing Committee of Health in the Academy of Science of South Africa and the chairperson of a committee to evaluate the COVID-19 health sector response in South Africa. So just before I hand over to our speakers, a couple of housekeeping rules. For the people attending online, please write your questions as the lecture's proceeding, and we have a team that will go through them and then present them to Professor Moshabela. For the people that want to ask questions at the end, if they could please just raise their hands, and then if Prof. Moshabela calls out your name, we expect you to turn on your camera. Hopefully you're not in your pajamas, and we would like to see you when you speak. So lastly, we will show a QR code at the end of the lecture for the people that are online, and for the people in the room, it's in your program and you can scan that on your phones to get CPD points. So with that, I'm very proud to hand over to our speakers, and Professor Tollman, the floor is yours. Thank you.
We're going to show a short video, but while we're getting that sorted out, firstly, thanks so much. It is a milestone, and Professor Mahdi, I was joking with your predecessor, with Martin, that one of the values of doing longitudinal work is that while the participants age, none of us do. And of course, that's the case, and welcome also. I know that there are colleagues and friends on the in this hybrid forum. But it really is a wonderful opportunity. We appreciate it. Of course, it does mark a milestone, and we really do value and appreciate. I know that there are colleagues who've traveled down from Bushbuck Ridge. Thank you for doing so. And really, although colleagues in the room are friends as well, I'm in no doubt about the distinction of many of the people, both online and listening to us, who've been willing to come, and we'll share with you. In many ways, the whole program of work that we'll share is a network model. It is not an in-house model. It is based on collaboration and sharing with people who share common values. And in that sense, we've also been fortunate to build and sustain partnerships at WITS, partnerships across the country. Thank you, Professor Moshabela Musa, for being with us, as well as more broadly. But I have to say, and it's not for the first time, that WITS has never let us down. The opportunity to, in a sense, thrive through the ups and downs of building a program of work has been very, very special. And it's something that WITS in the first instance, Medical Research Council in the second, and more recently the Department of Science and Innovation have enabled, notwithstanding the partnerships that Maria rightly span the globe, a fair amount of the global south, and a fair amount to insight into what makes research actually. And so again, we're set. We're going to show this short video, and part of the purpose is not everybody has spent time in Bushbuck Ridge. You may have spent time in Bushbuck Ridge a while ago, and it's kind of to show and just set a context as we start.
Moving to rural northeast South Africa in the early 1990s was to redress in part the almost exclusive focus on urban research and to bring to light the health and development problems facing the marginalized rural populations of our country. To do this, we brought the best science to bear, collaborating with outstanding scientists both within and outside South Africa's borders, and have done so for 30 years. We have forged long-standing partnerships with local communities and learned much about effective public engagement, so vital to sustained and ethical research in communities like these.
This unit believes in the intrinsic value of public engagement And if we do believe in the value of longitudinal health research data, then we need to make sure that the community and the service providers that we work with trust and respect us, and we need to trust and respect them.
As a public engagement officer, we learn a lot from our communities. We meet with different leaders and other stakeholders. So I think the unit also is doing fair to our community because when we look on our staff that are working for the unit, the ones that are coming from the villages that the unit is operating. So we are learning a lot with these communities, and the communities also are learning a lot from us.
The 1990s spanned the late apartheid years and early post-apartheid period, as well as emergence of the HIV and AIDS epidemic. Early work focused on how best to support government in developing health systems appropriate for the new South Africa. We quickly realized that the lack of reliable information was a serious obstacle to informed planning and resource allocation. Drawing on lessons learned elsewhere in Africa and in Asia, we set up a health and socio-demographic surveillance platform covering whole populations in Bushbuck Ridge. Through this, we have learned of the profound health and social changes affecting these populations and others like them.
Three things struck us forcefully. Of course, the heavy impact of HIV/AIDS, and particularly on families. The surprising rise in deaths from stroke, particularly among middle-aged and older women, and the pervasive effects of labor migration. All of this points to a complex health transition along the phases and stages of the life course, from childhood through childbearing and parenting into middle and older adulthood. We recognized this was probably the extreme end of patterns unfolding across the continent, perhaps more intense in rural South and Southern Africa, and that there was little precedent to inform health and social systems. And beyond that, the breadth of disciplines needed to get to grips, across biomedical sciences and social sciences, environmental and measurement sciences, all needed to be brought to bear. Looking to the future, it's clear we're confronting complex patterns of illness, with effects on health and personal or community development that often are not predictable. I expect we'll seek to better understand health and well-being among adolescents and youth, as well as adults and elders, as they seek fulfilling lives and careers across the lifespan. These are great challenges where poverty is pervasive and societies tend to reinforce rather than combat inequalities. Grasping risk and resilience, key to durable mental health, as well as appreciating multimorbidity, appearing all too young, will no doubt be key. Clearly, we must devise new, more effective and sustainable systems of healthcare and social support to take advantage of the parallel revolutions underway in digital innovation and communications, in data handling and analytics, as well as genomic research. And work to engage stakeholders, community, government in the first instance, but similarly non-governmental organizations, as well as the private sector where appropriate. This can help to set priorities, target investments for greater returns, as well as potentially create jobs. And fundamentally, we must do all this in ways that support new generations of scientific leadership throughout their careers. The intersecting and layered epidemics, pandemics, and the intersections that we encounter in South Africa, and to a degree the region and the continent, with an intensity that is seldom, if ever, found elsewhere. And clearly that poses dramatic challenges if you're trying to restore the dream. South Africa's had a tough ride, and it's the case that that's affected the health and the development and reinforced the inequalities of our communities. There are many people in this audience, many people online who've their lives to addressing that. What we're sharing is simply one contribution towards that. What inspired us at the time, firstly within South Africa, were two graduates of WITS, Emily and Sydney Clark, who worked together with Amelia and Edward Jiley to set up the work in Phulela in KwaZulu-Natal, that then became the Institute for Family and Community Health in KwaZulu-Natal. They pioneered this so-called community-oriented primary care. It seems so normal to us today. But 60, 70 years ago, that approach to interdisciplinarity and working with small-scale census studies was really innovative, and it's been taken up in high-income, middle and lower-income environments. But equally outside the country, in Bangladesh, in Matlab, where the cholera trials, where oral rehydration therapy was found, was an important influence. And that ends the presentation. Didi, I think switch it off. So Matlab in Bangladesh, still thriving. And at the same time in West Africa, I was introduced to both Michel Guerin, working in Senegal, in Niakhar, and Peter Abi in Bandim in Bissau. And at a meeting that Michel hosted in Niakhar, Peter Abi's comment really struck a chord when he presented work titled An Unplanned Longitudinal Study. And somehow that seemed to speak in various ways to wanting to create a platform that could sustain multiple lines of work. Much closer to home, WITS and its community medicine department then, but not only in community medicine, in pediatrics, in medicine itself and others, were really contributing to my cohort and generation of medical students spending time in rural parts of the country. And so the health services and then health systems development unit were important platforms for that experience. And a couple of slides that you'll see, that's Emily and Sydney on the right. Fortunately, some of us were at Matthew Chersich's inaugural lecture. And so it's not, we got it. Okay. Okay, so you have Emily and Sydney on the right. I don't have a photograph of Amelia and Edward Jiley. Edward came through malaria work, and Amelia was one of the leading nurses. And this was the so-called health center that was the inspiration, 60 years ago, for then Minister of Health, Henry Gluckman, and the idea of a national health service based on a network of health centers. There's no question to me that that is as timely now as it was so many decades ago. It was inspired, it was informed by the national health system in the UK. It intersected with the Boer Commission in India and many other dimensions. I've spoken about the Health Services Development Unit and a couple of fairly well-known figures in this picture. So we all have visions, we all have aspirations, and this is some of where we position ourselves in Agincourt, essentially to bring the best science to bear, to address the kind of challenges and complexities, to enhance the quality of life and productivity, as well as inform public policy and programs. And I'm sure that many of us share this. The question is, so how did we start? How did we get there? Well, this was, as Kathy said on the video, this was the very early 1990s. They were the late years of apartheid. Things were changing, but they hadn't changed yet. But there was a lot of fluidity. And there was a sense that nothing could be the same again. And this is kind of one used to look at. For those who are younger, this was the patchwork of Bantustans, the euphemistically named homelands, that on the back of the Native Land Act in 1913, on the back of apartheid, was where the great majority of South Africans were consigned. And Gazinkulu in the rural northeast was a place where the university has established a foothold. I know, Shabir, from a comment you made, you've been there, others have been there. Martin, you brought a team to visit, and many of us in this room share that. So following this approach of community-oriented primary care, we then set out to define a particular area. In fact, the purpose was decentralized healthcare systems. We had a Ministry of Health influenced by WHO, influenced by UNICEF, that was very high on ambition and pretty low on experience. And the question was, how in a rural environment would one actually deliver care? Yes, there were mission hospitals, and those contributed with their clinic networks as a basis for the rural healthcare system. But in a way, it was really a hospital service. And this was the environment away from the tar road, away from the hospital, away from the railway line, to try to understand who were rural South Africans. How did they live? What did they die from? And very much, what would be the ways to approach healthcare? This was on the back of Soweto, on the back of the 1976 uprising. Attention was grabbed totally by the urban. And the question was, well, what is going on in this rural environment that it turns out has much more empathy, the region of southern Mozambique, parts of Zimbabwe, and so forth. So early work really did set us on our way. As I say, we were asking this question of how best to develop rural healthcare systems, and how did rural people live? What were their lives? And the very early findings in demarcating an area and establishing who lived in that environment were revealing. In the first instance, the best estimates were about 50,000 people. Fair enough, we thought that was great. Count the people, it was almost double, bordering on 60,000. That told us anyone who was writing about these environments didn't know what they were saying. Second thing was, so what do people die from? And that's why the mortality program work Kathy took on, initially mentored by Michelle Guerin. It seems so obvious now, but there used to be different instruments, an instrument for children, an instrument for women who were pregnant, an instrument for adults. And the very simple act of simply cobbling these together was the start of having integrated instruments for verbal autopsy, which are becoming a bigger and bigger part now of routine, not just research and health services. Applying this, we learned a couple of really key things, and I've said this more than once. HIV was clearly profoundly affecting the society in so many different ways. But we were amazed that levels of stroke, particularly among older women, were as high as they were. And that was really very influential in at least the way we developed the agenda in this program of work. And then similarly, in one of our earlier publications, even published in 1999, and I have to say, with the help of a magical statistician and demographer, which Michelle Guerin really is, we were able to see that this looked strange. The trend line that you see going down suddenly had a disjunction. And there was a suggestion that those particularly reproductive women in the 20 to 44 age group, that their mortality was getting worse. And I was quite touched when I glanced at the paper for the talk to read the phrase, "The window is still open to intervene." Well, we all know how rapid windows shut when we don't intervene. Yes. From those very early periods, drawing on the experience and the legacy of the Health Systems Development Unit, our Medical Research Council and University Unit began to evolve, and we learned about very profound ways, and that this was a different reality. It wasn't the ordinary reality that seemed to characterize the way healthcare systems, social systems were organized, and clearly new models of care were going to be needed. Nobody that I know is more loyal to the University of the Witwatersrand than Professor Kathleen Kahn. Her father was at the university. She grew up in the university. She was determined to do her PhD by published papers in the university. And that opportunity had just been made public. And I think, Kathy, it took you about 5 years before Shabir, your predecessor, Max Price, was the dean. He said, you know what, Kathy, just go and do it overseas. And that was the start of a very productive engagement with Umeå University in Sweden. A former vice chancellor, Louise Nongla, joined us there. Maria, a former assistant dean research, Beverly Kramer, joined us there to see how defenses actually happened, how the theses were put together, what sort of structure would characterize a PhD. And as you can see, several in the early cohort of scientists associated with Agincourt got their PhDs from that environment. And that drew us to the questions. I've shared these many times. What surprises me is how durable the questions are, decades down the line. Of course, these are the broad questions. Every piece of work have its critical questions, hypotheses, and so forth. But this was an environment of unpredictability. The determinants were going to be biological and social, and we must say environmental now. What do we do about it? And how do we then embed those interventions, when effective, into policy, healthcare systems? And clearly, we have some successes and some significant successes in South Africa, but we also have commitments and sometimes the failures. So how did we go about this? And of course, this comes to the platform. I'd mentioned Polela, Matlab, Nyahar, there was Narangwal in India. There were a number of platforms in Avrongo where vitamin A studies were happening. None of these platforms were interacting with each other. And partly by good fortune, we happened to be in London. We happened to be able to bring together about 5 of the African platforms. And although we were sharing our findings to see and get ideas as to what agendas might be, at least as valuable in that meeting was overcoming the differences between different groupings. And those were part of the very early stages of the in-depth network and what then became the Alpha Network and so forth. So the idea of having a strong evaluation base seemed critical. And the best way to describe it is along COPC lines to demarcate a whole population, and their colleagues based in Soweto with Vida. There is David Everett and colleagues working in Pretoria and elsewhere. It's very challenging in urban environments, but there is something a little bit more enabling in a rural environment where one can define villages or communities that much more easily and demarcate them that much more easily in order to establish a population platform. The whole population cohort essentially means you enumerate everybody, and you've got to keep enumerating everybody, and you've got to do it really rigorously, because that is your population denominator. One doesn't do this to give approximate results. One wants to give results that are at least roughly right, and that in general are creating the evidence base that we need, because there was very, very by way of evidence. And then the rigorous collection of every pregnancy outcome and birth, every death, subjecting that to some sort of an inquiry, and of course population movements. And population movements are very difficult. Deaths are fundamental. That's our business. I guess life is our business. But a death happens once. A migration, a movement happens time and time and time again. It is technically very challenging. And we were fortunate in those early days to have a team that became, in effect, migration specialists for the continent and also for Statistics South Africa, because you can imagine that a census captures everybody at one point in time. It cannot capture movement, and that's part of the strength of such health and socio-demographic information systems. And again, to spell a very simple principle: count everybody, then ensure that you are comprehensive with the pregnancy outcomes, and that is difficult, by the way. That is why neonatal and related challenges are there, and I think that is the strength, one of the enormous strengths of the CHAMPS network, so-called CHAMPS network, from which we're learning. But at the same time, every death and every movement, and in an environment like South Africa, the national and the regional economy is based on movement. It's based on movement and migrant labor. So it was absolutely fundamental to get to grips with that. And it puzzled me why the only application that HDSSs had seemed to be put to was to evaluate vaccinations. Now, you can't do anything more important than that. But the idea that this could be a critical tool for health, disease, risk, social, behavioral insights seemed to have eluded most colleagues. These were the days not only of individual consent, but also community consent. And it's a delicate balance, consulting with communities, gaining assent, especially from civic as well as traditional leaders, and then still trying to remain true to so-called individual consent, which is really important. It's really the graphic of this picture that's interesting, simply showing how we started. It was really pen and paper. And Lynn, you spoke at Linda Richter's book launch. She said exactly what I would say. Every textbook says, never collect data if you don't have a data system. Well, we collected data without a data system. And the data, the hard copies go up, and one's panic rises commensurately. And again, we drew on the best support we could. In this particular instance, it was Michelle Guerin and other colleagues who we'd happened to meet abroad. Michelle's work was in France, but as I say, in Senegal as well, and he happened to join a similar institution for a few years abroad. But today, thanks to colleagues, and there are many in the audience, but I can only single out some of the leaders of those teams, Xavier, yourself, Cho, and various others. It's all electronic, it's all digitized. And I found Sam Clark's advice very helpful. I said, Sam, we're going too slowly. We've got to digitize everything. He said, no, don't digitize. Let our partners digitize. They'll make mistakes. We'll be in the second. And I found that rather helpful. Cho, again, has led Agincourt, but in many ways, regionally, the idea, and I'm talking about Ziwa Kabadula, who's sitting here, has led the idea of linkage between a population database and records in a clinic, which for the most part, at least in the environments we're discussing, are paper-based. And that has enabled this near real-time linkage, and it's an instrument we're only beginning to exploit and to understand. But it's absolutely fundamental, because data one obtains from clinics is based on clinic records. It does not tell you who does not have a clinic record. It does not tell you who does not arrive. And those tend to be the people with the greatest illness, or sometimes the migrants, as we will refer to a little later. And this is simply to show that there's a strong trail of both Agincourt-based, nationally based, working particularly with the Burden of Disease Unit at the MRC and Statistics South Africa, but also a lot of support to Tanzania, a lot of support to Kenya on achieving that. So before I talk to this slide, the platform has turned out really, versatile, every bit as versatile as people say, and I know Kathy's going to talk about it later, but the real test, because this is what one's brought up with if you live in this world, the real test was, could we pivot with COVID? And Cheryl, thank you for coming, but Kathy, you'll talk to it. But it was no stretch to pivot. Platforms of whatever kind are highly versatile. And I actually found, I can see Peter, you're there, I actually saw in a Wits paper not that long ago a quote attributed to the late Sidney Brenner. And the quote was, the model you choose is as important as the question you ask. And again, that certainly resonated, and up to a point, I think, has helped. So yes, there's been a platform that is versatile. It lends itself to quite complex analyses. Complex, by the way, is not something necessarily to aspire to, but the methods, the ways in which design of studies can be done, there's certainly a versatility that we've been able to take advantage of. What I had not realized at the time, and there are various colleagues in the room, but particularly Michelle Ramsey, as we started to bring in a genomics platform, is the ability to create multiple platforms. Platforms below the individual level that a population platform like this is based on. So the platform itself draws particularly on measurement and population sciences. Demography, Clifford, you and Gloria here, demography, epidemiology, statistics, computer sciences. But the ability to insert sub-platforms is really strong. And I once upset one of our dear colleagues, Mark, I don't know if you're watching, Mark Collinson, when I was looking for a phrase and I said the platform really allows us to move from the molecule to the mob. Mark pulled me aside and said, you know, mob is not the right word to use. And he's right. He's right about that. As well as supporting cohorts along the life course and a range of trials and helping us learn that there are hybrid designs. A cohort study can support trials. A trial can become a cohort. That can support qualitative work and mixed methods. That has been something interesting to learn. But here, Rian Twine and Simon Koza, who you saw in the video, and I think Simon, you're with us, did something very, very simple. There was a problem. Too many people were the 60-plus pension, especially rural women. The issue turned out to be so simple when you looked at the data, basic descriptive data, that people lived far from Home Affairs offices and they simply didn't have ID documents. And you can get that from the most basic analyses. And yet there was a terrific response from the provincial Home Affairs office. I wanted to show this slide, partly I know, Karen, you're here, because the setup of the aging cohort has coincided so well with the introduction, first of the broader SALT regulations and then the narrower SALT regulations. And we are quite far along from understanding. The question is, what effect do SALT regulations have on many different things? The goods that are held in shops, excretion of sodium, any effect on blood pressure whatsoever. I was deeply skeptical. It's one thing to hope you might find that in Johannesburg or Cape Town, Bloemfontein, Mangaung, or eThekwini. You think you're going to find it in Bushbuck Ridge? Well, watch this space. There are interesting findings emerging. So I'm going to go rapidly through a series from the team that Cho leads with Xavier, but there are a number of others in the room who are responsible for both data management, Daniel, and building up the data analytics. And part of the strength of it really is the length. It is a truism that you can do something for too long, and maybe you need to change, maybe you need to shift. But there really has been a great value in spanning this period from pre-1994, post-1994, a difficult period post-1994, and having the data that reflects that. And to start with that, and many, Cheryl, Shabir, others who've been leading colleagues and spokespersons in the COVID era, and in some ways I'm sure we're still in the COVID era, that deterioration at the end of the curve in overall mortality, even in rural South Africa, even in rural Mpumalanga, not necessarily the rural epicenter of COVID, is really quite evident. And as Cho shows on the next slide, similarly, you see that life expectancy at birth. Of course, the major dip is HIV, and it was an absolutely profound dip. And I'm going to show the population pyramids that Cho compiled with Daniel and others. This is simply to show, and it's really intriguing, the dotted lines. So the solid lines are Agincourt, with red being female and blue being male. The dotted lines are the South African data. And interestingly, the life expectancy at birth, it makes a difference. Life expectancy at birth versus life expectancy if you're 25 and so forth. That in fact, those trends of life expectancy are that much higher in this rural Bushbuckridge environment. And maybe it was rural when we got there, and maybe it was rural for the first 10 years. It has really changed. And we're looking forward, Musa, to sharing some of that with you. It still seems so apt to talk about this is the Black Mountain of HIV and AIDS. This is now covering essentially the start of the baseline, 92, 93, all the way through to 2020 and 2021. And you can simply see from the shape of the curve, HIV and AIDS mortality. This is mortality. And the thing I must underline in terms of this data is that it is all collected. It is all primary empirical data. And of course, you must compare it with Statistics South Africa. You must compare it with KwaZulu-Natal, compare it with other environments. And there are statistical methods to apply the data and amplify it to wider environments. But as you can see, with regard at least to HIV/AIDS, that has been a success. That's been an extraordinary achievement in South Africa, insofar as HIV/AIDS is concerned. And of course, we have, again, an enormous population on long-term antiretroviral therapy that we don't understand a great deal about. And the lighter shade, so the dark, the black is HIV and AIDS mortality. The kind of gray just above it, or deepish purple just above it, are other communicable conditions. So very closely linked with the HIV. Then you've got the non-communicable conditions, but they are not separate. They do interact. Those who have HIV are going to be more at risk with regard to NCD and the like. And I can see with the photographs, I'm not calling folks out, but it's key folk who've been involved in these particular studies. And what you can see here on the left are the Agincourt data in terms of cause of death. And on the right, Cho has contrasted that with South African data, pretty much using the same scale on the X and Y axes. So it's very interesting, the parallel between the national picture and the Bushbuckridge picture. As well as mortality, we've had cohorts that can be joined and that have allowed, and Xavier has led this work in both hypertension incidents as well as HIV and related incidents. And this particular slide, which focuses on fertility and childbirth, tells the story of immigration. The top curve was the fertility of Mozambicans who came across the border as refugees and then self-settled in this Agincourt Bushbuckridge environment. And you can see how over a relatively short period, their child-rearing pregnancy outcomes have converged with the Bushbuckridge and the South African picture, which is really far, far below 3. I think the slide Cho and I were talking earlier today, there are a few questions we've got about misclassification when it's starting to go below 2, but that's why the issue of birth outcomes, stillbirths, neonatal are really very important to collect accurately. Excuse me. Are successive curves of temporary migration. Red referring to men, to males, and the blue referring to women. There are only two key take-homes here, but you can take them home with a strong degree of certainty given the scale of this work over successive years. The first is that labor migration is a constant. It is with us. And the second is women, and especially younger women, are joining the migrant labor force. And that's been going on for several years that others, including Dory Posel, have written about. The picture here is clear. We know that South Africa has an extraordinary social transfer system. Pensions are the largest, but they're the child support grants. There was the issue of the social relief of distress grants. The direction of travel from this slide is absolutely clear. These are poor households, but they are better off. They are better off. There are significant degrees of difference and inequality in an apparently poor area of, I mean, this was one of the poverty nodes of South Africa. And at the same time, there are significant tails, those who are getting left behind. What you can then do, and this work was led by Cho and company, what you can then do is link your understanding of socioeconomic with your understanding of cause of death. In this particular case, what you can see in 1 and 2, or A and B, whichever they're named, A and B, you've got a pretty linear relationship. In other words, there's an inverse relationship. The lower the socioeconomic status, the higher the mortality from HIV. And that's why it's going from high to low. Even in a uniformly poor environment of South Africa. But the relationship with various of the non-communicable conditions on the right-hand side is less easy to show. So the team shown have been experimenting with getting further household data. There are many reasons why asset data is the easiest to get from a household and the most transferable. Income is extremely difficult to get from a household for obvious reasons, but consumption and expenditure data gives you a fairly good picture because people are willing to share what they're spending as opposed to what they're earning. And if you do that rigorously and carefully, we're starting to come up with certain areas where the asset index that has served us well can now be superseded in some environments by understanding the data on expenditure and consumption. And this is showing that there, in fact, suggests a serious gradient in disability, that those who are poorer in this poor environment are going to have more disability. And the disability is a composite score that is captured here. So, bear with me. Population pyramids are actually quite complex, but it is in its way unique to have pyramids that go from a baseline, 1 decade, 2 decades, 3 decades. And if you look first at the top left, that is the so-called low to middle income environment. That's what it was, even a low income environment. And that was the picture 1993. You move to the right, 2001, HIV, very limited, if any, antiretroviral therapy, and you can see that eating away at the base. You move to 2011, and already you can see wonderful improvement with regard to the youngest children because of prevention of mother-to-child transmission, and similarly, antiretrovirals are beginning to be taken up much more widely. But the 2021 picture is remarkable. People are living longer, and they are progressing through the pyramid. The proportion 50 plus is now 40% higher than it was in 1993. feedback is important. That goes without saying. You're going to sustain relationships with communities, with people. These are real communities. There is stuff happening in these communities, and there is rivalry in these communities. It's extremely important to maintain, to build, to sustain the relationships. And it's not just the feedback at an individual level, it's also the question of dialogue around findings. And here, I think Paulina Tindana, Michelle, Rian, you among others, have helped to, in a sense, bring a certain kind of systematic approach when it comes to the more complex feedbacks. MRIs, magnetic resonance imaging, that Nomsa and Ryan are dealing with in older people. How do you feedback those sorts of results? But certainly genomic results cannot really be dealt with at an individual level. Thank you, Kathy.
Hi, everybody, and hi to all of you online. So Steve has largely presented some of the findings that have emanated from data collected through the platform. What we're going to do now is to present some findings from work that has been nested within the platform. So studies that have been conducted through cohorts or trials that Steve had mentioned that are conducted in the first instance, work along the life course. And I will start presenting some of the work we've conducted on adolescence, and then Steve will come back on to talk about some of our work on older adults and the elderly population. So starting, why a focus on adolescents? Clearly they're a vulnerable group. They are at a transition where there are changes in context. They're leaving school with, in most instances, a very poor education, going into environment with few post-secondary training opportunities, limited employment opportunities, forcing many of them into this circular migration Steve was talking about. Many of them are leaving the somewhat protected environment of school with more contained relationships, which I will talk about, into more serious relationships or more less contained sexual relationships and first pregnancies. High levels of social and emotional stress. We have learned a lot about gender-based violence and inequalities, depression, which we've learned a lot about, and all in this context of poverty and food insecurity, the high HIV risk, which Steve has mentioned. And we've also learned, if you look at the graph on the bottom right, where we've got this dual burden of both residual underweight and stunting, together with a burgeoning overweight and obesity problem in adolescent girls and young women. And on the basis of what we've learned over many years of studies in adolescence, a series of interventions and trials have been underway in Agincourt. And if we look at the socio-ecological model, these have been taking place at all different levels, at the individual level, at the community and family level, and at the societal and structural level. And in fact, the very first one that was a steep learning curve for us, which was a conditional cash transfer trial, was really at the level of a structural intervention.
And this was the Swakoteka trial, or known, it was an HIV prevention trial known as 068, the nomenclature they use. But as you can see, there are a number of different trials, and I'm going to touch on just a few of them. The conditional cash transfer trial, the PI and a long-standing collaborator of ours, Audrey Pettifor. In fact, we learned a great deal through this trial, and much of what we learned has informed forthcoming work that we've been conducting and still work on in our adolescent portfolio. But we learned that staying in school significantly reduces HIV risk. And much of that is because school, with all its limitations in rural South Africa and the country as a whole, does seem to provide some protection around containing sexual networks for young people. It limits exposure to older partners, and it limits the number of sexual partners. It also significantly reduced physical intimate partner violence by 1/3, but had no significant effect on sexual intimate partner violence. We were interested in the fact that cash provided and promoted agency in adolescent girls, and that is because this agency is something that's permeating now into work that we're doing with adolescents and forthcoming work that we're hoping to do in economic inclusion of adolescents. So it was very important for us to learn that when cash was given to young girls, they were able to make decisions on their own, and that having cash to spend enabled them to gain independence from family members, improved relationships with their mothers in particular, but gained independence from male sexual partners. We conducted 2 cluster randomized trials in partnership with an NGO, Sonke Gender Justice, looking at community mobilization and whether community mobilization could reduce harmful gender norms, and whether that would be a vehicle for reducing HIV risk. We also looked at community mobilization as a strategy to improve HIV testing, uptake, and linkage to care. The latter trial, I can't present any results. They embargoed at the moment, pending publication in Lancet HIV next month. But the trial on looking at gender norms did show that community mobilization decreased negative gender norms in several different ways. That men did report more equitable gender norms, that women were reported being less likely to have experienced intimate partner violence. And so that there were some positive results from community mobilization, an intensive and well conducted trial in several communities in the Agincourt study area. We were fortunate, following the conclusion of the cash transfer trial, that we were able to conduct follow-up of the cohort over several years. And we looked at mental health of the adolescents, specifically at depression. At baseline, 18% of the adolescent girls and young women had depressive symptoms. And we learned that the cumulative incidence of HIV amongst those who were depressed at baseline was significantly higher. so that depression led to a higher risk of acquiring HIV. This was a new finding. It was well known that HIV could result in depression, but it hadn't been established that depression could result in HIV. So opening another window as a potential avenue to address HIV risk, deal with depression in adolescent girls. But what we learned as we followed up these young women in further waves was that by the fourth wave of follow-up, these were annual follow-up visits, more than half of the sample, nearly 60%, had reported depressive symptoms at least one time point. So that depression is a major problem in adolescent girls in this environment. We learned also of an association with depression and pregnancy, that there were those with higher depressive symptoms were more likely to become pregnant. And the study platform allows us also to look at the offspring of participants in our studies, and we were able to therefore look at the outcomes in the offspring of our cohort. And we were able to track the impact of depression in mothers on the developmental outcome of their infants. Maternal depression before a pregnancy had no impact on the socio-emotional development of their offspring, but depression during the perinatal and early childhood periods had a negative impact on the infant's socio-emotional development. Everything that we were learning about depression in this age group meant that learning how to intervene in an environment where there was simply almost no services in the public sector to deal with mental health was really an imperative. And so we looked at digital delivery of mental health services as would this be a feasible strategy to deliver services for this vulnerable age group where there seems such an important need for services to deal with depression. And so we were able to develop and pilot, which we are coming towards the end of the pilot trial, an intervention using digital technology to deliver a tailored psychological therapy, namely behavioral activation, to adolescents in the 15 to 19-year age group, specifically those with depression. So we developed the app, co-developed with adolescents in this age group in the Agincourt area. The app is based on two stories, a song contest and a soccer match. And within the story is embedded behavioral activation therapy. And behavioral activation focuses on linking mood and behavior. It's a derivative of cognitive behavioral therapy, and the app is supplemented by short weekly phone calls by trained peer mentors. And our pilot randomized controlled trial is to determine whether adolescents in this environment will they use the app? Will the peer mentor aspect of the intervention increase the acceptability? How much supervision will the peer mentors actually need? And very, very importantly, how will we link those with severe depression and with suicidal ideation to the very limited services within the public sector? The primary outcomes of the RCT are feasibility and acceptability, and we are hoping to see whether there is a signal in terms of the impact of the intervention in reducing depression, symptoms of depression. And then there are a range of secondary outcomes, of course, looking at mental health outcomes, also looking at risk behaviors, and we are looking at executive function and social cognition as mediators along the pathway. We're also looking at socioeconomic outcomes. Going back to the outcomes of the cash transfer trial, so depression was a major outcome that spawned this new work that's underway and coming to a conclusion. But another outcome was HIV incidence at the end of the trial. So at the time that during the trial, HIV incidence was relatively low, but at the time of school leaving, when the cohort reached the ages of 19, 20 years old, incidence had increased very, very rapidly and to high levels, around 5%. And it made us realize that focusing on young adolescent age groups was not enough, and that we had to turn our attention to the young adult age group. And so our next trial was a trial of HIV self-testing, and that was at a period where, at a time where HIV self-testing was still relatively new. And our question was, can expanding HIV self-testing options improve HIV prevention and care for young women in the first instance? But not only that, could we use this as a vehicle to reach the hard to reach in the population, namely young men? And could this be a way of facilitating linkage to care? And so we were targeting now the 18 to 26 year age group, a little older than we'd been working with before. And we randomized young women either to an arm where we invited them to the clinics for HIV counseling and testing, or to an arm where we gave them a choice, either an invitation to a clinic for HCT or to receive an HIV self-testing kit. Remember, this was a time where this was not common. And if they chose the HIV self-test kit, very new, we would give them an additional 5 kits and ask them to distribute these amongst their peers, but particularly their male partners, and to take part in the trial in the same arm that they were, either the invitation to the clinic or the choice of clinic or self-test kit. And what we learned was that there was a very high uptake of the self-test by the young women, so high acceptability and feasibility. 95% chose the self-testing over HCT. Of those that chose self-testing, 94% tested at home, and the majority, just over half, tested alone. Very few harms were reported. It's easy to use, and more peers and partners were reached by the self-test than by the invitation to go to the clinic. But still, a very big gap remained how to reach young men. So with the success of the HIV self-test trial amongst adolescents, we then decided to nest an HIV self-test trial in another cohort, which Steve will talk more about. But this is a cohort now of older adults and a cohort from 40 years and older, right up to old age. So I'll not talk about the cohort, but I'll just talk about this HIV self-testing trial. This one had 3 arms. One arm was rapid testing and counseling by a counselor. And then another arm was the self-test kit, and a third arm was both rapid testing and self-test kits. There were nearly 3,000 participants. And our results were, there was no significant difference in uptakes between the arms, but there was a preference for self-testing. Most those with the self-test kit tested at home, and the most likely reasons were privacy and concerns around stigma and convenience. There were no adverse effects. And what was striking was that there were lower depression scores in those in the self-testing group. So the takeaway message was HIV self-testing in this older age group is a safe and seemingly preferred option for older adults. And in the cohort, what we had learned was that and Steve, I'm sure, will touch on this, was that there's little known, but a very high risk, sexual risk behaviors in this older age group, where there was both not just transmission, but acquisition of HIV, and no targeted HIV prevention strategies for older people. And the last thing I want to touch on before Steve comes back to talk about older adults is, again, the versatility and the opportunities that a research platform such as we run in Agincourt offers. And that is the ability to link different data sets. And to ask questions, therefore, that no one data set or study can answer alone. And so we had a group that was interested in how life course or economic exposures over the life course might influence aging outcomes. And being able to link data from the Agincourt HDSS platform going back several years to nested cohort studies. In this instance, the cash transfer trial and cohort follow-up, the HPTN 068 trial and subsequent waves of follow-up, and the aging study that Steve will talk about, which is the acronym is HALSI, enabled a whole host of analytic work and questions to be answered. And so you had 2 nested studies, an adolescent study and an aging study, where you had overlap of participants because you had parents and grandparents in the aging study whose children or grandchildren had been participants in an adolescent trial, all of whom were nested in the health and sociodemographic surveillance system. And because we had the right ethical permissions, we were able to link these data sets and ask all manner of questions that none of the investigators could have dreamed of at the time of setting up those studies. And I mean, there are a couple of examples of what we have learned so far by linking the older participants in the aging study with HDSS employment data. We learned that longer duration of employment is associated with higher cognitive scores. By linking older participants in the aging study with cash transfer households, we were able to learn that the cash transfer injected into those households protected against death, but only amongst the most educated with the higher asset indices, not amongst those in the lower socioeconomic brackets. And so just to bring out again the versatility and the power of working within a research center in a data platform with the collaborative and the linkages between different studies and different partners and different collaborators working together is able to yield more than the sum of the parts, if I've got that right. So, Steve, I think you come back in now. I hope there's a smoother changeover.
One of the things that struck me with the work on depression in adolescents is the tremendous care taken with regard to protocols relating to ethics in practice and relief of distress protocols. So here you have this environment of really depression at scale in young people and very, very little safety net. And so tremendous care, if I've got this right, Cassie, tremendous care in terms of the way, not just adverse events, but keeping contact. Because this is the kind of thing, if it goes wrong, it's going to blow your study, it's going to blow the hope for major trial completely out of the ground. And yet, social development is overwhelmed, and there's already enough evidence to suggest that depression is a risk for so many things. It's obvious. Frankly, it's obvious. But depression is a real risk for not making it in life, not getting out of high school, and then whether it's further education or a job or whatever. And so that's part of what this is directed at. The issue of integrating data sets is something now, and there is a focus, whether it's in the university, whether it's in the faculty, on this issue of data and data sets. Something, I don't know if Roy Zent is here, Martin, but Martin, Roy, among others, have played pivotal roles, as well as Redcap that we're all familiar with. But Scott Hazelhurst and Catherine Chubatungi, based in Nairobi, are two of the principal investigators of a sister research hub, sister to the heat, climate change, and infants and maternal research hub. This particular one is focused on multimorbidity. Very unusual that WITS as an institution has gained that parallel investment from the NIH. And in this instance, the issue of multimorbidity is quite profound. In high-income environments, many environments, there is a gradient. As people age, they tend to accumulate more serious chronic conditions, primarily because of HIV and because of the accelerated disease onset that tends to happen in conditions of adversity, conditions of poverty, and so forth. We've done away with that gradient. This is tough. This means that in middle age, many folks, this idea that rural is pastoral and calm and quiet, forget about it. These are highly vulnerable and violent environments in which many risks manifest. How do you restore the dream? How do you work? Well, I think you've got to understand it. And as you can see from strong data here, whether it's women or whether it's men across the age span, this gradient in multimorbidity is effectively lost. An interesting thing happens, at least within the Agincourt network of clinics. So you've got to be quite careful. What's generalizable, what's transferable, and so forth. But what you can see on the left is that if a person only has raised blood pressure, their movement along the continuum of care is less good than if they have hypertension and HIV. And those who know might say, well, what's surprising about that? Well, the first thing that's interesting is it really happens. There is an HIV advantage. There's no question about that with regard to care. But it doesn't only have to be HIV. It can be hypertension, diabetes, and mental health conditions. The progression through the continuum of care is significantly better. So this question of new models of care, this is a partnership with a few intramural units of the Medical Research Council. Know Your Numbers is looking at pension queues. And the first effort, and here you can see Jane Simmons, Xavier, and Charles Parry, who leads the alcohol, tobacco, and other drugs MRC unit, the project manager, and the two co-PIs. The issue here is it ain't all going to happen in clinics, and it ain't all going to happen if people pitch up at clinics. And Jane, you've done a ton of work with regard to clinics and lay health workers and trials around that in that Agincourt context. But to me, it's a smart idea. What are other environments that older people engage? And they are pension queues. And so, although hypertension is the screen, the idea that this could be a way of screening across a range of chronic conditions is what's arising. And similarly, not everyone goes to a pension queue. More sophisticated people are beginning to use ATMs and, in this instance, queuing up by a supermarket. And again, you can create a system, and we'll see what it's a pragmatic trial, what it resolves. So we're focusing now outside the formal health service, engaging with community in various ways. And Carolyn Audette and Ryan are doing, to my mind, refreshing work with traditional healers. How many times have you heard, whether as a student, whether as a young professional health worker or other, we should have a relationship with traditional healers? Well, none of us know how to do it. That's been my experience to date. And the presentations on how to do it seldom take us forward. This, to me, seems to be making some headway. They formed a relationship with the Kukuka and wider group of traditional healers, and they're asking the HIV counseling and testing, Kathy, you were emphasizing the self-testing, but what about traditional healers? There are many people who go to traditional healers who may or may not use clinics. What about traditional healers as a community responding in terms of HIV counseling? And so that work is currently underway. Similarly, it turns out that HIV levels among traditional healers is way high. Why is it so high? Because scarification, cutting with instruments that may not be properly sterilized, is still common. And so the idea of not just teaching about that, but introducing PrEP, introducing the kinds of interventions that became everyday with COVID is really turning out quite significant. And as you can see here, increasing healer use of PPE, as well as training healers to undertake HIV counseling. And these are two studies that are underway and hopefully will eventually graduate to full-scale trials. This issue of how to engage community and how to draw community into healthcare systems in a meaningful way is difficult to envisage outside of the local and district environment. And what started off as relatively marginal work within Agincourt has turned out to be really significant. And ironically, it's very significant in helping us work with integrated data sets. So all the work's at an earlier stage. Among the leaders are Xavier and Cho, who's sitting here, as well as Catherine and her team in Nairobi, because the work's in rural South Africa and urban Kenya. And in this particular instance, trying to find a theoretical way that informs work with communities. And this next sequence of 3 or 4 slides, to me, has turned out extraordinary, because the idea of patiently working with communities, patiently trying to engage and develop their agency and their ability to engage on a more equal level with health service managers and clinic practitioners and so forth, is out to be extremely important. Setting up regular learning spaces. The quote reflects the pathos I've always felt. There are many protests in Bushbuck Ridge. You put a tree across the road, you light a little fire, you stop everybody going. Sometimes it's much more violent than that, and nobody listens. So what's the point of the protest? And this speaks community stakeholder. There have been a lot of service delivery protests. They did not accomplish much. It is time to shift our way of thinking and initiate dialogue, collaborate, and create sustainable partnerships. Well, it's easy to say, but can you really strengthen the accountability, strengthen the governance of a healthcare system by involving and integrating community that much more effectively? And a lot of it is happening through community health workers of various kinds. Jane Guja's work with lay health workers and Xavier in clinics, and the community health workers as a bridge between community and the primary care services. And we knew, and it took a while for penny to drop, that these folk were doing something right. When the district turned around and said, we've got hundreds of community health workers, please come and train. We want to build their agency. We do want to integrate them more effectively and create that relationship. Shifting back to multimorbidity, this is the Agincourt Research Lab. This is the kind of work, June, that you have led in Agincourt. And I think Shingi is here, who leads, Shingarai, who leads the lab. But Alicia and June have asked questions about cutoffs and thresholds. Well and good, but how well do the studies that have derived the cutoffs in mostly European origin populations, how well do those transfer to the South African and the African environment? And the answer is lousy. They do not transfer very well. And one can test that, as Alicia has done with hemoglobin A1C, and as you can see in the bold, very low concordance between a hemoglobin A1C measure and venous blood glucose. And yet hemoglobin A1C is a standard diagnostic instrument for diabetes. Yet if you use hemoglobin A1C in this environment, you end up defining diabetes 4 times as much as fasting glucose defined diabetes. And June has come to the end of a phase of work working with colleagues in Malawi and in Uganda, which has been looking at this difficult challenge of chronic kidney disease and trying to understand what's really happening. Are people dying before they reach the kind of age groups of middle age? And what are the instruments that would help us get it right as far as thresholds are concerned? And again, in work that they have just had published, this concern that ways in which estimated glomerular filtration rate, that is simply a way of saying how much sodium do each of us excrete in our urine, that estimations are profoundly flawed if we simply transfer the so-called equations from European origin populations to African ancestry populations. Well, if it's happening in diabetes and it's happening in chronic kidney disease, you bet it's happening in an awful lot else. So it needs generations and younger generations of colleagues to build this up. And as far as it is concerned, as far as the multimorbidity, the thresholds, and the interactions with the genomic as well as the wider environment, I think, Michelle, with your and the Sydney Brenner team's help, there's a portfolio beginning to emerge. And I guess, Michelle, that's not accidental, but it focuses over the longer period on obesity and related cardiovascular risks, kidney disease, as you're working, June, dementias and depression, as Kathy was referring. But one starts at the bottom and you build it up step by step, and we will get the breakthroughs, we will get the publications, but we will get much more besides. And so, as the conclusion says, we cannot assume these findings transfer. We've got to inskill ourselves, our students, and our students' students to undertake these kinds of work. The last element along the life course that is becoming a significant part of what we do is realizing, as we saw from the population pyramids, that people are living longer. People are living longer, people are living later, but as we said in the abstract blurb, the issue is not just years to life. The issue is, can we add life to years? And in this instance, the issue of cognitive function and the continuum between cognition and cognitive impairment and dementias of various kinds are a very real one that we are beginning to encounter in all the communities that we work. And I'm sorry we don't have Lenore Manderson's picture there, because Lenore is leading the work on caring and caregiving of older people. And all you can see here, Nomsa, you're with us, the work that Nomsa with Ryan are doing, together with Brent Tipping, together with Victor Ngomezulu, to create our understanding and our platform of cognition and dementia in these environments. And if you don't look for it, you may not realize that it's there. So Kathy made both of these comments. You'll see them on the slide, that this issue of education has a profound effect on cognition, and it even plays itself out. The issue of inequality in South Africa is obvious for all of us, and it means that education at every level has been so flawed in the rural public education sector. And yet, no cognition, no education versus some primary versus some secondary has a major impact on cognitive function through the later years of life, and that is sustained whether it's women or men, although as you can see, the patterns are really quite different. And similarly, and Kathy, you referred to this, this is the curve that shows that duration of employment that's based on the data of integrating those data sets, employment from the HDSS, as well as cognition understanding on the older adult cohort, simply putting those together, and I'm sure it wasn't so simple, is exactly what enables us to start to ask and answer the question, well, what is the relationship between employment and cognition? And as you can see at the bottom, this talks to this very attractive idea that people don't seem to know that much about, which is cognitive reserve. What is cognitive reserve and where does it come from? Similarly, this issue of who I speak to, do I have a network of people who I speak to as I grow older, is very important. And for those who don't, that's very problematic on that continuum between cognition and dementia. So I'm going to end this section, and then I won't step up again after Kathy has spoken, on the issue of environmental determinants. They are clearly keys. We've talked about a life course, but the issue of determinants in various ways. Social determinants, environmental determinants intersecting with the biological. There's no question that most of the care of younger and older people when it's required is from within the family. That's where the care comes from, and it still comes from that. And it's been exaggerated because of HIV, and I guess we don't know quite what the effects are in relation to COVID. But with regard to the pension, which women are eligible for at 60, and now men are eligible for at 60, you get a very interesting, different picture when it comes to how those pensions relate to mortality. So on the curve on the left, you can see what happens, and this is at a population level, when women gain the pension. Women gain the pension, and at that solid line in the middle of the left-hand graph, which is the 60 years, you kind of see a plateau. She's now empowered. She has agency. It's a cash transfer. She's able to use this in various ways. We know much less about what happens with the men. But look at the right-hand side. The men get the pension at 60, and suddenly there's a complete discontinuity. There's a worsening of mortality. What is happening? Why should there be a worsening of mortality on the right-hand side as men gain the pension? And of course, we're speculating about that. And of course, one of the questions is, well, is it binge drinking? What actually is it? And then you find a bit of an improvement, and then it worsens. Karen Ginsberg, with Mark Collinson, with others, Corbus Herbst on the Sapron and in-depth front, and Philippe Bocquier based in Belgium, are the people who have helped us work out how the hell to handle migration. It is extremely challenging technically, and they've made the progress with it, and part of the guarantor of that progress has been its application across a wide swathe of East, West, and Southern Africa. And essentially, they've used mortality as their critical outcome. And yes, there are fundamental differences. Those who move across the continent have far worse mortality. And this is talking about internal migration. This is not cross-border migration. This is internal migration within a particular country, the sort of migration we have in South Africa linked to labor migration. And it's highly, highly significant in terms of as a risk for mortality among women and men, and particularly among women. There is an unresolved issue in South Africa. We just live with these high levels of risk. How do they, as Mark Collinson has pointed out to me, healthcare is not necessarily the most important thing that a labor migrant is concerned about. But how do they link to care? And it is the case. They link to care much less. They link to chronic care much less. And the men link to care, as we all know, vastly less than the women link to care. But interesting, as the slide shows, the linkage to the private system, again, it's intuitively one can grasp, the linkage to the private system is far higher with labor migrants than it is with those who are settled. And again, that's raising questions not just about migration, their linkage to healthcare in general, but the relationship between the private and the public system. The last of these, in terms of social and environmental determinants, is work that Wayne Twine has led for a long time. Laurie Hunter has been one of his partners. Wayne Twine, he has been there for decades. He's an associate professor in animal, plant, and environmental sciences, and very perceptively nested a cohort, the Sustainability and Communal Socio-Ecological Systems cohort, within about 600 households of Agincourt, and has been following since 2010. And all the graph is showing is, even in this rural northeast, a drier part of the country, there's a significant rainfall gradient moving from the west, which is the escarpment of the Drakensberg, to the east, which is the Kruger National Park. And on this last slide, I've really combined. The first thing that Wayne's work addressed was the question of death and what did death mean to a household and the security of a household. And it turns out that the natural environment is critical as a buffer for those households that are the poorest. And ask yourself, well, which are those households that are actually the poorest? There's been a significant improvement in household food security, although the reliance on ecosystem services remains high. And it's interesting, as Wayne tries to link rainfall with food security and subsistence production, there is some subsistence production, and child growth and development, it turns out that notwithstanding in the upper frame the improvement of food security, in the lower frame, in the red, you can see that various measures of child nutrition and malnutrition are pretty prominent, particularly aggravated by COVID in that period in 2020 and 2021. Thanks, Kathy. Thank you.
So I'm moving on to look now, 30 years on, at assessing the impact of the work that we've been doing. And this is just showing a small number of the PhD students that have passed through. As a couple of the pictures are students that are still with us in advanced stages of their degrees. some have finished and are still with us or with the school. And this looks just at a little bit more detail at over 20 years, because in the first 10 there weren't many. We've had 154 graduates, most at doctoral level. But if we look at the 42 current enrollments, and we look at the ratio of female to male students, we've got 2-to-1 females to males. If we look at the Black and Asian students to white students, again, it's more than 2-to-1, and a very strong South African and African regional enrollment of almost 70%. We have a program of data interns recruiting young graduates from the Bushbuck Ridge area or environs who join the data section for 6 months, sometimes 12 months of a mentoring program. Some stay on, some have been with us now for a few years, and others move on to sister units or elsewhere. But a very productive capacity building program that Daniel with Cho and others run in our unit. We have been an incubator for programs at the university and in the faculty, going back to the late 90s, early 2000s, a forced migration studies program within our research center, which evolved into what is now the Migration Center, African Center for Migration and Society, led by Joe Vieri. The Demography and Population Studies program, and so glad, Clifford, that you're here with Gloria. That is a partnership with the School of Social Sciences and the School of Public Health, with a very strong regional footprint in the student body, as you can see in the map. We were the startup base for Priceless South Africa, which is now the very successful MRC WITS unit and Center for Health Economics and Decision Science Research, led by Karen Hoffman. And we supported the startup of the Degale Health and Demographic Surveillance System at the University of Limpopo in the mid-1990s, which is now the Dimamo Population Health Research Center. Dimamo is one of the SAPRIN research nodes, one of the 3 rural nodes of the South African Population Research Infrastructure Network. SAPRIN is supported by the Department of Science and Innovation. You can see the map there with the original 3 nodes now joined by the Gauteng Research Triangle, GRT Inspire based here, and with the Cape Town node about to start. We've been instrumental, Cho in particular, in the Alpha Network for population-based HIV/AIDS data in Africa, where Cho has been instrumental in rolling out the linkage of population and health facility records that Steve mentioned. And we've been played a major role in the evolution of the in-depth network in migration and health that Steve was talking about, in mortality and cause of death through verbal autopsy, and more recently in June's role in chronic kidney disease. And of course, we've been a partner in RWGen, led by Michelle Ramsey. We played a startup role in Carter, the Consortium for Advanced Research Training in Africa, and continue as one of the research institutions. So we play a national and a regional role in several networks. Data sharing and public access data is a role that we regard as very important, and we contribute to that in various forms, sharing our data in a anonymized form, ensuring all the ethics are in line, but also making sure that there is a period where those of us in the South that have generated the data have a chance to analyze and publish that data before it goes online in this public access forum. Our evidence and the impact of our evidence on policies and on programs is at a variety of levels, population level. Steve mentioned the SALT regulations that Karen and the Priceless Group have been so involved in. We contributed empirical data to the modeling, and Steve had mentioned now our role in evaluating the impact of that work. At the healthcare system level, we have played a role in locally and provincially in various forms, and in two particular instances have been demonstration health districts, on the one hand for decentralized TB services, and on the other hand for integrated chronic care. And Kirsten Klipstein-Grobusch was very involved in that effort with one of our doctoral students, Sutta Ame, and very productive on both of those instances, informing policy and programs around those two health service and health system initiatives locally, provincially, and nationally. In particular around data, strengthening, extending, and validating national data. We've played a role in contributing child mortality data to COMIC, the Committee on Morbidity and Mortality for Children Under 5. We've played a role working with the South African MRC Burden of Disease Unit around mortality, and a particular role around migration with Statistics South Africa, Mark Collinson and Karen Ginsberg, contributing to the establishment, of a national migration and urbanization forum for South Africa, bringing together various stakeholders, NGOs, government, and academia to consolidate knowledge around multiple sources and to build the evidence needed to inform around this very important social phenomenon in South and Southern Africa. At the individual level, Steve spoke about the social grant, the child support grant, where it seemed we were missing the most poor with the government strategy, and how the basic data that Steve mentioned, just getting to the right people at the policy level, in our instance at provincial level, Home Affairs, resulted in the kinds of intervention that made a big difference to people on the ground. And then at the global level, our work with verbal autopsy and the tools and analytic work and software for analysis of cause of death informed World Health Organization instruments around verbal autopsies that are now have now fed into global efforts around moving verbal autopsy tools from research into routine vital statistics, civil registration, and vital statistics. At the time, 2020 March, when the COVID pandemic hit, the HSRC did a national survey to evaluate the impact of lockdown nationally. It was an online survey, and I think many of us probably completed that survey. But of course, it missed the rural population in the country. And HSRC turned to SAPRIN to see if we could help, and it was Agincourt that was able to respond literally within a week to 10 days through moving very rapidly, pivoting our field-based data collection system to a expanded call center. We were able to respond and to generate an adequate sample to be able to bring into that survey the voice and the experience of rural South Africans around the impact of the level 5 lockdown in those early days of the pandemic. And so the ability to very rapidly turn around and adapt the infrastructure of our research center from this field-based, as you can see, population, household-based, face-to-face, in-person data collection system to the call center, and Daniel is here, and Ngoni, and everybody, Obed is here, who was running these 2 shifts a day, fetching the call center agents from their homes at 5 in the morning and taking them back the second shift at 9 at night in order to be able to deliver for the country the experience of rural South Africans. Was something that we felt was very important. Again, with SAPRIN in the COVID response to lockdown, we were able, the 3 rural, established rural HDSSs undertook COVID surveillance, and we were able to do comparative work in northern KwaZulu-Natal, Limpopo province, and Mpumalanga, where Agincourt is, to look at the experience of these rural populations under lockdown. And at that time, and we continue with Mark contributing to the Department of Science and Innovation's National Policy Data Observatory on a regular basis. Around now, not just COVID, but through the SAPRIN nodes, contributing data to this important policy forum. And then, while through 2020, all fieldwork, all our studies were withdrawn from the field and moved where possible to telephonic data collection, and where that was not possible, fieldwork was suspended until we could resume work in 2021 in the field. We mounted with Cheryl and colleagues, a huge team of colleagues, a SARS-CoV-2 transmission study in Agincourt and with PHRU in Jupiter. And that was the only fieldwork that was conducted in the field. And it was such a learning experience about how to do that work safely, because it was a rapid response. I think by July we were in the field. And so much we didn't know still at that time. about SARS-CoV-2. But it was an amazing experience and continues to be in this collaboration with NICD and PHRU. And I can't even begin to present the findings, but just to say, with this longitudinal work, we're able to present what we knew at the end of the second wave, at the end of the third wave, the cumulative learning that came out of the study. And as I say, you know, Cheryl's photos up, Jackie Kleinhans, who presented a wonderful PhD interim seminar in the school just a few weeks ago. But they represent a massive team. But what we learned, you know, by the end of the second wave, and you know, Jackie's work papers in her PhD at the end of, you know, the third wave, you know, just the very high rates of infection, both in the rural and in the urban setting, but the extraordinarily high rate of asymptomatic infections. And I must say that we were spared in Bushbuck Ridge, in Agincourt, spared very high mortality, and we very grateful for that. With our team in the School of Public Health, and also with Izincha, with Francois' team, but work led by Karen and Hoffman and Sue Goldstein, we were able to look at how the COVID-19 pandemic impact the opportunity costs of COVID-19 pandemic, and with Cho's work linking the population and data with our health service data, we were able to look at trends in the chronic disease visits. And Cho looked at HIV, hypertension, and diabetes. And you can see in the three graphs at the trend line up until the start of the pandemic, where with HIV and hypertension, the visits were increasing, and then how with the onset of the pandemic, the fall off in the attendance at clinics, and how the attendance, although it did increase again with HIV, for example, hasn't yet reached back to the levels that one would expect, particularly not for hypertension. And the partnership with Priceless and Izincha was looking at, with qualitative work, is looking at the comparing rural and urban experiences of healthcare workers and the community under lockdown, and their experiences of the pandemic itself. And with some of these results showing the impact on service attendance, which had fallen off, the impact on the mental health of both community members, and impact on mental health of healthcare workers, we could see that health services were really struggling. And we had a group in Bushbuck Ridge initiative, and it was a collaboration, a partnership between our unit, but the December Foundation, an NGO in the area, and also the Tinswala Hospital and Bushbuck Ridge Services, that aimed to support and advise the healthcare facilities in how to manage the epidemic in our area. And there, Bianca Moffat, Jacques Dutoy, and Rian from our our group were very, very active and played an important leadership role in this area. Key areas of action were providing the materials, the handbooks, the guidance, adapting materials from elsewhere, translating them, making them applicable for the services in our area, and providing training and supervision and support to the clinics and the hospitals in the first instance, but also responding to the education sector that were really left, and schools and educators, and responding to their need for training and guidance. And finally, the impact of our work over 3 decades to the community that we've been working in. And there's been a substantial contribution to the local economy in the area. And Ngoni has been working to try and quantify. And while this is not 100% worked out yet, we have employed over 3,200 women and men in this rural area. And it's an area with very, very high unemployment. National levels, we know, and this is the recent Stats SA quarterly labor force survey, but national levels, unemployment's at 34%, and youth unemployment approaching 50%. And how perhaps worse might it be in a rural area? And just in the last 10 years, and at an approximate level, simply through salaries that we've paid, we've brought in more than 240 million rand into the rural households, into in the villages that we've been working in. Because one of our commitments is that where the skills exist in the villages that we work in, we employ from the study villages. And then there've been spin-offs, just by virtue of our being there, support to local services, village caterers, maintenance and repairs of a minor kind that can be done in the villages that we work in. Just increased spending in those villages. And then the staff that we employ learn workplace competencies, develop technical skills. Having a WITS employment on your CV is a very strong, and the staff are therefore better equipped to secure jobs elsewhere if that's what they choose to do. And then children of our long-serving field staff secure bursaries through WITS. And for many, they're often the first member of their household to go to university. So the last section of this talk is moving on to what about the future, and putting community-based evidence to work. So what about our future work? Our future work is to build on the existing initiatives, to introduce new work, and to strengthen the methods that we use and to innovate new methods. And we're very fortunate in that we have a new data and analytics complex that will be opening in November, launching this new building, which allows us to expand, and space is a premium on our little campus in Agincourt Village. But there is new work. I say it's new because it's a full RCT that we're embarking on now, the Insembo trial, which with DPHRU, the Developmental Pathways for Health Research Unit, led by Shane Norris, Nicola Christofides from the School of Public Health involved, and Tseho Siabi, a PhD student, her PhD is on the development work. I say it's new, the RCT, but the truth is there's been 10 years of development and work that's gone into this informative work. But that is a trial that's dealing with risk for metabolic disease in adolescent girls and young women. But the mental health work will remain central to the adolescent work that we do. And we're moving into economic inclusion, and we'll be working closely with the Southern Centre for Inequality Studies at WITS. And we're very excited about this new departure. In our work on older adults, again, mental health and cognitive decline and dementia is central to that. But sleep studies, which Xavier has been leading with Corinne in physiology, again, is an area that we want to grow and we see as an innovative and important. And we are very pleased that our work is expanding and leading out of Agincourt. And again, this is work on older adults, aging and cognition and dementia, moving out from Agincourt to the Sapron nodes and to a national survey and national surveillance. And we hope that that work will get underway. Methods development is a thread that's been ongoing and will continue. Verbal autopsy with minimally invasive tissue sampling is now funded, and Shabir will be leaning on Vida to help and guide us through that. Harmonization and integration of data sets. We've spoken about that, will be ongoing, and work on excess mortality and cause of death across African and Asian environments is underway and yielding results that are clearly showing the impact of the COVID epidemic across Asian and sub-Saharan African settings, work that Cho and Querbis from Sapron are leading. And that is work that's newly started and will be ongoing. And models of community and service integration to strengthen health system governance and accountability, again, will be a work that is in its infant stages and will be ongoing. Patient-oriented clinical platform led by Alicia, June, and Ryan. Key innovations are the impact of wearables, the app development for depression, and new generation probes for lung and cardiac assessment. Jacques Dutoy is working on that, and it's the center of his PhD. And Jill Nelson with Brad Reset working on Parkinson's disease and Parkinsonism, and the MRI work that Steve mentioned. And then overlapping opportunities have such potential. FDR, the Expanded Freshwater and Terrestrial Environmental Observation Network, similar to Sapron, is a research infrastructure supported by the Department of Science and Innovation, have selected 6 settings in the country, one of which is in the Lowveld. I think overlapping with Agincourt as the with its population database was seen as a strong advantage, but this just provides an unparalleled opportunity to link detailed real-time environmental and climate data to the rich population data we have and the natural resource data that Wayne is responsible for, and will underpin the questions and variables that we're interested in to understand the role of indoor and outdoor pollution in heart failure and cognitive change. So transition to transformation, restoring the dream of health for all using community-oriented evidence, the title we chose to give to this lecture. And we've pulled out just some of the key words we put into the abstract for this talk. Adding life to years. Adding years to life is not enough. It's not just about the numbers. It's about quality of life. It's about the soul of what we do, and the soul of how we do it and how we go about our work. Government's aspiration of a long and healthy life for all South Africans bars the question, what about those that are not South African? And the Limpopo's Health MEC, Poppy Ramathuba's outrage that hit not just our news, but was on BBC this week, yielded both outrage and support over her treatment of a Zimbabwean patient in a public hospital. But we believe that all are valued in life, and that value underpins all we do. But we believe that all are valued in death as well, and that underpins our focus on mortality and the importance of how mortality is measured, and that it be measured accurately, and that everybody be counted and accounted for. Evidence on health and well-being of all is critical to equity in development. All work in an environment such as Agincourt addresses issues of equity, and that is what we believe. And that the consequences of pervasive and persistent inequalities, and how to overcome these, how to protect health in the face of rapid socioeconomic transformation, both the good and the ill that can come with this, is what we try to do. Rapid change in health of Africans presents challenges little recognized by today's health and social systems. For us, that echoes the enormous value of longitudinal data in bringing these challenges to the fore. In our experience, there have been 3 ministries that have really provided us the strongest backing for our work. Statistics South Africa, DPME, the Department of Planning, Monitoring and Evaluation, and the Treasury. And evidence details profound changes in health and well-being of South Africans since the demise of apartheid, challenging preconceptions and crystallizing an emerging reality. Compared to many population-based research centers like us, Agincourt covers a considerable breadth in our work, and I think that's come through in what we've presented. And because of this, we can comprehensively map the rapid and multifaceted transitions communities in this part of South Africa have undergone over the past 30 years. Our 30th anniversary coincides with WITS's centennial year, and it was former Vice Chancellor Adam Habib, who in his inaugural address talked of Agincourt bringing hope to the people of Bushbuck Ridge. And certainly empowering and engaging communities and local capability is fundamental to decentralized approaches, and community-oriented evidence is necessary to this. And for decades, if you think back to the CARCs that Steve talked about, South Africa has been a global leader in generation and application of community-oriented evidence, and that has influenced and inspired efforts from Africa to the United States. But to reclaim this position and to put it to work bridging the extreme inequalities in the service of human development will require at least commitment to strengthening and using local data systems to help target and evaluate interventions and hold government to account. Relinquishing the exaggerated authority and hierarchy held at provincial level, enabling local initiative and supporting this to thrive, and appreciating the dynamics of health and social transition and warranting a transformation in approach. We would not have been able to do our work without the rich partnerships that we've enjoyed. And we have not begun to acknowledge everyone. We've tried to show individuals who, on our slides, who have been major contributors to our work. But for each one that we have shown, we've probably missed others over the 30 years of our work. And for each one that we've shown, they have worked with a team, and we've not been able to show everyone, of course. They have been our funding partners, and without them, we all know work would not happen. And for everybody that we have shown, we have to recall that over the period that we have worked, there have been very close collaborators and that we have lost. And we remember them because we have gained and learned from them. And that we will never lose. So in that way, they have stayed with us. And then there are irreplaceable people who work with us, our project managers, those in our data section. There are others that we weren't put together, our admin teams. We run a little campus up there, and there are so many people who keep us going. And then the leadership team, and we all work so closely together. We receive invaluable support from WITS HR and Finance, from the WITS Health Consortium. WITS Rural Campus is home from home, and we always feel so privileged when we spend time there. And without the Agincourt community, none of our work, none of this work would be able to happen. So thank you.
We should take a short break.
You're eager to go, but I think that we're going to try and not keep you for too long. I'm very honored to be invited here tonight to comment, and having been in Bushbuck Ridge for about 5 years or so, and I'm seeing familiar faces. It's such a pleasure to see and witness these lessons that we are getting today. 30 years is a long time. And I'm not sure that Steve and Kathy are going to have another opportunity like this to be celebrated for the 30 years of work that they've put into the same community for such a long time. And I think it is worth taking a moment just to, I think, first celebrate them for what they've done. And those who, and most of you probably do research, just running one project is hard. Just running one research project is hard. And trying to run a program of work, I ran a program of research in Bushbuckridge for about 4 years. It's hard. Trying to get payments done at vets in Joburg. It was hard. So now imagine two people putting in 30 years of work in spite of all of that. And this is in the middle of them trying to justify their existence. You will have, they haven't told you all the stories. The amount of criticism that they got for just doing surveillance, observing people without interventions. It was harsh. And I know because we were doing the clinical side of work, implementing antiretroviral treatment. And we were important at the time. Every time they've had to present to province, to present to government officials, they will get a lot of criticism. They have had to justify why they needed to continue to exist and why their work needed to continue to be important. And when you think about that criticism and you see the importance of population surveillance has come today, the importance of data science, where all of that have come today, it is very painful to reflect back and actually think about the criticism that they've had to endure. Just look at the Saprin network. Everybody agrees that this is important. It's an important infrastructure to build for the country and to build in multiple parts of the country and use it to contribute to the broader national data observatory that the country is now committed to. But if they had given up at that time, wouldn't have it. In 2006, we sat with a guy called George Renier, who is at the London School. Many of you might know him, a demographer, to discuss the problem of fragmentation between what we were doing in the HIV clinic and what was happening in the communities. And for me, I understood it because, and Francois, you'll remember this, when we rolled out antiretroviral treatment in 2004, we thought that we were going to have a whole lot of people queuing up to come and get treatment. They didn't. And you'll be sitting in the HIV clinic receiving a patient with a very low CD4 count of 4 or 5. And you're wondering, it's already 2006. Why is this person coming with this low CD4 count when ARVs have been around for like 2 years and are in rural Bushbuckridge? And for us, it became obvious that it's almost like you're sitting there in the clinic waiting for people to get infected in the community, for their CD4 count to drop, and then only when they're really sick, they come to you in the clinic. And even though my introduction to research was clinical epidemiology, it made sense. It became necessary for me to start thinking about what happens upstream, what happens in the communities, what happens in the household. And it was through them that I began to learn the potential contribution of population health and the community work that they were doing towards what I was doing in the clinic. So this notion of population and clinic linkage became really important. And if you have seen the work that the guys in Africa Center have done, ARI have done, you will also begin to appreciate those connections. And pretty much everyone now wants to do that. What used to be very different disciplines in clinical epidemiology, where we were focusing also on people who are already using services, and the population health, we are now bringing them together, and you see it in the scope of work that they've done, whereby different disciplines are now coming together. You listen to their talk, it's almost like you're thinking, are you the jack of all trades? Like pretty much doing everything? But it is out of necessity. When you're looking at a community and the problems that communities have, you have to respond to all of the problems that they have, all of them. So now, all of a sudden, you're not only dealing with only the convergence of diseases, you're dealing with problems of aging, you're dealing with problems of environment. All of these things, they affect that community that you're looking after. And then you begin to appreciate population health in terms of its broad concept. But you know, as they learned as well, very quickly, that you cannot just do population health. You need services. If the services are poor, you're not going to be able to make a difference for the population. So for me, I think that it is really worth taking the time, not just tonight, but perhaps over the next few days, over the next few months, to continue to celebrate the work that they've done. When I arrived in Bushbuckridge at the end of 2005, I found Rianne Twine there. And she'd been living there for what, 14 years? And I said to her that I'm going to be here in Bushbuckridge longer than you. I lasted only 5 years. And she continues to be there. Xavi is here. He has been there for a long time with his whole family. They have the same concerns. They want their kids to go to school and to go to nice schools like we all do. They also want the kind of soft life that we want to enjoy in the city as well. But the commitment that they've had over such a long period of time is what we get in the fruits that we see in the work that we see here and the impact of it. I learned from them that building relations, to achieve success, you have to build these relationships and build them over an extended period of time. Not just with your staff, with your funders and your research collaborators from different parts of the world, but also with the communities. Because whenever communities had a problem, they go to them with a begging bowl, wanting help. The kind of things that you have nothing to do with, they would ask you for help. School fees. I mean, look at their problem. They had to respond to issues of orphans. It was not part of their plan, but they had to respond to that. So I suppose from where I stand, I look at the 30 years where at the beginning, all they really wanted to do was to count people, count births, count deaths, maybe observe migrations. But that's all really they started off with. But you look in the last 10, 15 years, they've been having to move to interventions, population trials, intervention trials that they've been doing. It did not just happen. And I can tell you there were times when they depended on big funders like the Wellcome Trust, and the Wellcome Trust will change their priorities and withdraw funds. All of that they went through. And so we've also seen, as they've indicated, that there's been a lot of people that have come through that whole infrastructure. PhD students that have come through, many. And now all of these PhD students are in different parts of this world, many of them. For me, I just think that, Steve and Kathy, I've had the fortune of working with you for that short period of time that was really long for me. in Bushbuckridge. I've had the fortune of seeing how you work. When you are expecting guests to come and visit, and by the way, we would get people that you would not get a chance to talk to. Vice chancellors would come to Bushbuckridge and would have dinner with them. And if I came here on campus, trying to get to the door of the vice chancellor would be very difficult. But we would take them out to Kruger National Park. But what was really important for me to observe was how Steve and Kathy would plan for those trips, the detail of the plan that went into it. This is something that we don't get taught. We don't get taught these things. And yet we are expected to run research programs and research units and centers. I always said that Steve is very smooth, but it's really about diplomacy, science diplomacy. Steve and Kathy have a lot to teach many of the people that are coming behind them as the next generation of researchers in science diplomacy. It's not there in their plans going forward, and it's got to be there. If it's not there, we're not going to be able to benefit from the experience that you have had over the years. I also think that, and I'm wrapping up, don't worry. I also think that from having watched what you've done, your ability to pivot is incredible. You know, we often start things with a clear plan of this is what we want to achieve, and we want to stick to it. And success comes from having stuck to what you wanted to do from the beginning. But having watched you, it was always about how can you learn, reflect, pivot. And I get it. Underneath it all is this research infrastructure that you've got. But you've had to pivot a lot. Now, having to pivot multiple times over a period of 30 years is not an easy thing to do. So for me, I think that I have taken lessons from there to say that actually, you must not be afraid of change. And we've all seen it, even with COVID. We needed to pivot. You had priorities for research for one thing, but you needed to then change and do it on COVID or something else related to COVID. So pivoting becomes a necessary part of our skills and our ability as scientists, as researchers. And these are lessons that we can learn from the likes of you. There are many soft skills that you have, lessons that you've learned over the years that you need to continue to share with us. It is interesting to look at the science of what you've done, but I think that there is more you have to give beyond that. Kathy, you've been teaching, you've been in charge of the PhD program for like more than 10 years in the school. When you saw what was happening at UMIA and learned lessons from other parts of the world, you brought it here. You raised the standard of the doctoral training in our school here when we were doing PhDs with the Ben Sartorius and them at the time. And those lessons did not just end here, we took them elsewhere. Now it is a norm that you can do a PhD by publication. When you took over the program here, it was not a norm. But UMIA was doing it. Now we're all used to it everywhere. So I just think that this presentation does not really capture all of the impact of what you've done from where I stand, having observed the journey over the last 15 or so years. And I think that it will be good for you to continue to think about what else can you share with all of us so that we can learn from that, especially the soft skills. The problems of today are so complex that our traditional disciplinary silo approach doesn't really work anymore. We need to work in transdisciplinary approaches. This is what you do. You work with people from all sorts of walks of life, from science, disciplines that you bring together. You work with them. These are the skills that we all need nowadays. We are having to now work with people who are in climate and so forth, environment, which is what you're doing, and you've been doing for years. So all of those skills are the skills that the next generation of scholars are going to need to be able to tackle the nature of the problems that we are faced with nowadays. And I hope that you can really take that to heart and assist us in going forward. We've spent a lot of time tonight listening, and we've absorbed, and unfortunately we can't stay here the whole night, but I do want to take a moment to thank you and celebrate you for the work you've done over the last 30 years. And I mean it from the bottom of my heart, having seen the many things that you have done and you've had to deal with and you've had to endure, as well as the contribution that you've made, especially around building research infrastructure in this country. Not just the two of you, but your whole team. I think that there's been such a huge contribution that we appreciate, that has contributed to the landscape of science, especially population science in this country. So thank you for what you've done, and we will continue to learn from you. We are open to learning from you for the lessons that you still have to share with us going forward. We will continue to observe what else comes out of the work that you've been doing and you'll continue to do. But I think that please do really take to heart the need for you to share with the next generation of scholars how to engage in the way that you've been engaging for you to be this successful in a period of 30 years that requires so much resilience in terms of the work you've been doing, as well as the skills around science diplomacy that you've had to embrace and use to achieve this success. Let me stop here, colleagues, and thank you for listening tonight. I'm going to hand over to the Dean to close the session for us.
And good evening, everyone. So we were planning on having a question and answer session, but clearly I think we've run out of time, unfortunately, courtesy to a few AV hiccups. But thank you for bearing with us. And I'm just going to do the ceremonial thing. And first and foremost, please, I'm going to invite Steve, Kathy, and Mossad to join me. And while you're doing that, Steve, Kathy, you certainly represent the epitome of commitment to a university, of commitment to the country, of commitment to a community in terms of the work that you and your team have done. And I think what was really remarkable of the talk is really highlighting the role of the many others in the research unit and the extent to which they've made sacrifices and the contribution they've made to the research unit. And certainly, this is not a celebration just of the two of you and your activities, but it is a celebration of the rest of the research unit. So everyone from the research unit, take a bow. So please join me. We've got a few gifts for you. Mosa, I think thanks for making the time to come out to the side of the world. Yeah. And I think you make my job much easier with the summary of the remarkable work that's taken place.
Thank you so much.
This we'll give to Kathy.
Thanks. Thanks, Steve.
Thank you.
Okay, so at this stage, I'm going to bring this event to an end. And first and foremost, again, just to thank the audience, those that attended in person, as well as those that joined us virtually for embracing this occasion with us. And then just to invite everyone, for those of you that do have some appetite after this fascinating talk, to join us for some refreshments outside. So thanks again for joining us.
Thank you.
Thank you.